Cortisol secretion, it is regulated by ACTH, which is produced by, again, anterior pituitary. Now the hypothalamus controls ACTH by CRH. We are repeating this line. And the serum cortisol level inhibits the release of CRH and ACTH, that is by the negative feedback inhibition. This much we have learned. Once again, revising the facts. So this is the adrenal gland. This is the cortex. This is the gyrota fascia. This is the medulla. Cortex has 3 layers: GFR, glomerulosa, fasciculata, and reticularis from outside to inside. Now, which hormone they produce? The glomerulosa produces mineralocorticoids, that is aldosterone. Fasciculata produces glucocorticoid, that is cortisol. And reticularis produces androgens, that is sex hormones, right? Now, interesting part is this glomerulosa is not under the control of ACTH directly. It is basically under the control of renin-angiotensin. Whereas this cortex part, the fasciculata part, and the reticularis part, they are under the direct control of ACTH and CRH. Now, why it is important to know this fact? That I will let you know. Now, this medulla we also talked, which is the core of the adrenal gland, which is a neuroectodermal part. It is made up of chromaffin cells. It will produce catecholamines. Which are the catecholamines? Epinephrine and norepinephrine. Now, the GFR corresponds with the salt, that is salt, sugar, and sex hormones. Now, this is just to make you remember things. Salt, sugar, and sex hormones. The deeper you go, the sweeter it gets. That's just a way of remembering things. Coming to the physiology part, the adrenal cortex produces mineralocorticoids by the glomerulosa, glucocorticoids by fasciculata, androgens by the reticularis. I hope this is easy. And if you get confused, you should know the GFR formula. G will give M, F will give G, R will give androgens. So now coming to the cortisol part. What is the role of cortisol in the body? Cortisol is basically a hyperglycemic hormone. It's a diabetogenic hormone. It causes rise of blood glucose. It increases insulin resistance. So it opposes the insulin action and increases gluconeogenesis, especially in the liver. And that causes increased hepatic glucose output. At protein metabolism level, it will have a catabolic effect. So it causes breakdown of the skeletal muscle protein. So key metabolic action is where? On the skeletal muscles. As a result, it causes degradation of the muscle protein. And this protein is converted into what? Glucose. So there is gluconeogenesis. It causes decreased protein synthesis. That is why long-term steroids will cause what? Myopathies, muscle weakness, especially the proximal muscle weakness. So the amino acids which are released are converted into glucose in the liver, that is gluconeogenesis. In lipid metabolism, what it does? It causes worsening of the dyslipidemia. It causes rise of VLDL and LDL and causes a dip in the HDL, that is the good cholesterol. What it does to the fibroblast activity? It causes decreased fibrosis or decreased fibroblast activity. And as a result, there is breakdown of the collagen. And that causes formation of stria, the skin, the subcutaneous tissue collagen, it is broken down and there is stretching, the stretch marks, and they are red in color, that is purple stria. In fat, adipose tissue or obesity or in pregnancy, also there are stretch marks, but these stretch marks are white or pink. They are never purple. Purple stria are very characteristic of hypercortisolism. What do they do to the bones? They causes osteoporosis. So that is, they weaken the bones. How do they do that? They do that by decreasing the osteoblast activity. and increasing the osteoclast activity. So the osteoclast is to osteoblast ratio. The activity of osteoblast is decreased and osteoclast is increased. So the glucocorticoid exposure is the most common etiology of secondary osteoporosis. So if we get a chance and we talk of osteoporosis, we will learn, otherwise for your information, what is primary osteoporosis and what is secondary osteoporosis. Again, as a rule, anything which is happening because of the organ defect, primarily the organ defect, it is primary osteoporosis. That is, the bones itself are weak, mostly senile osteoporosis. If it is because of some drug or disease, then it is a secondary condition. So here the steroids are causing osteoporosis, so it's a secondary or the steroid-induced osteoporosis. So 20% of all causes of osteoporosis are because of the steroid exposure. Now, there is a significant risk for the development of fractures after the glucocorticoid exposure, especially the older age, above 65, prolonged glucocorticoid exposure, that is more than 3 months, especially if you have a positive family history of osteoporosis and you have a low calcium intake, that is, you are vulnerable. Glucocorticoids, they also inhibit the bone remodeling and causes increased fracture risk. So what are fragile fractures? So the fragile fractures are the osteoporotic fractures. And what does they mean? What do they mean? They mean that fracture happening due to a fall or injury, which was not supposed to cause a fracture in a healthy bone. Okay. Suppose you had a fall, your bones will not break. But if another person of your age and gender falls or hurts or gets injured by the same injury, same degree of injury, and the bone breaks, then that person definitely has a weaker bone, that is osteoporosis, and that is a fragile fracture. Now, the glucocorticoid exposure alters the fragile balance between the osteoclast and the osteoblast. So the OC is to OB ratio is altered. Glucocorticoid stimulates osteoclast-mediated bone resorption and decreases osteoblast-mediated bone formation. So specifically, the two main effects on bone metabolism is, one is increased osteoclast activity and decreased osteoblast activity. Now, what happens on the peripheral blood finding associated with corticosteroids? You will have probably a very common opinion that steroids will cause leukocytosis. So the increased counts, the TLC will be increased. But this increased TLC will be mainly neutrophilic. It causes decreased number of B cells and T cells. That is, the lymphos are decreased. Eosinophils are decreased. Monos are decreased. So they are a signal for apoptosis of all these cell lines, but they will cause neutrophilic leukocytosis. And why does that happen? Because they bring all the neutrophils which were adhered. So they stop margination and bring all adhered leukocytes into the circulation. So marginating pool becomes part of the circulating pool. And the increased bone marrow release also of the neutrophils from the post-mitotic pool. So there is increased TLC, increased absolute neutrophil count, but decreased lymphos, monos, and the basophils. What are the mineralocorticoid effects? These were all glucocorticoid effects or the cortisol effects. So mineralocorticoid, in short, is the aldosterone. It is under the influence of RAS, that is renin, angiotensin, aldosterone system, the RAS system, and the mechanism of action is they will cause salt and water retention. That is a normal action. So mineralocorticoid coming from zona glomerulosa produces aldosterone, which is involved in the sodium-potassium homeostasis. So they maintain a normal balance of sodium and potassium. So they cause potassium loss and reabsorb the lost sodium. Target organs are kidneys, the sweat glands, salivary glands, and the intestinal mucosa. So aldosterone has effects on sweat glands, salivary glands, and the colon, which are essentially identical. The action is just the same, that is as it is seen in the kidneys. So the major net effect is what? To conserve body sodium by stimulating its resorption, or in case of colon, absorption from the intestinal lumen. It promotes sodium retention and potassium excretion. So the most important regulator of aldosterone secretion is RAS system, the renin-angiotensin-aldosterone system. And of course, the serum concentration of potassium is the guiding force. So if there is hyperkalemia, it will help you in losing potassium. If there is hypokalemia, it will shut down the RAS axis so that potassium can be conserved. So the renin produced from the juxtaglomerular cells in the kidneys. So you know, we will probably do the kidneys sometime. So this is the Bowman's capsule, and this is your PCT here, and this is your descending loop of Henle and the ascending limb of loop of Henle. Then there is a distal convoluted tubule, and this is a collecting duct. So just next to the PCT, there is a collection of cells in the blood vessels that is called the juxtaglomerular cell. Juxta means near. Juxta means near. So near the glomerulus. Near the glomerulus, there are cells. They are known as juxtaglomerular cells. They produce renin. So there is one is renin and one is renin. Okay, so you should know we are using the single N here, renin, and we are using the double N here. So renin is an enzyme coming from the stomach, which we will be doing the GIT next month. We will be doing GIT in January. So we will talk of renin there, double N. That is coming from the stomach. It's a hormone which is used in the milk metabolism. Here we are talking of renin, the single N. So renin is a hormone which is produced by the JG cell or JG cells or the juxtaglomerular cells, and they are helping in the renin this is the RAS system, renin-angiotensinogen-aldosterone system. So the cells of the zona fasciculata and the zona reticularis, they synthesize cortisol, adrenal androgens. So fasciculata is giving us what? The glucocorticoid. And reticularis is giving us what? Adrenal androgens. And what are the androgens mainly? They are the DHEA. DHEA, that is dehydroepiandrosterone and dehydroepiandrosterone sulfate. DHEA and the DHEAs. The DHEA and the DHEAs. They are the androgens, the male hormones. So the androgenic effect, that is DHEA and the DHEAs, they are precursors of the androgens and are converted in the peripheral tissue such as fat. And that is why what happens in PCOS? There may be rise of these hormones. Because of the obesity, they are converted into androgens. So that is why there can be adrenal source also of the increased male hormones that we see in PCOS, or a condition called non-classical CAH. Another condition called non-classical CAH, NCH. So what happens on the inflammatory response and the immunity response? Steroids are known to decrease inflammation and they decrease your immune system also. So the predominant effect of steroids is to switch off the multiple inflammatory genes such as encoding cytokines, chemokines, adhesion molecules, inflammatory enzymes, receptors, proteins. So they are all activated during the inflammatory process. So steroids go and shut down the inflammatory process, and that is why they are known as anti-inflammatory. And for their anti-inflammatory action, they are used where? In asthma. Now coming to Cushing's syndrome. Cushing's syndrome is a condition of hypercortisolism. So GFR, F is giving you glucocorticoid, and increased glucocorticoid production, that is hypercortisolism, is a condition we call Cushing's syndrome. So chronic glucocorticoid excess. Now the commonest cause is exogenous steroid treatment. Yes, the commonest cause of Cushing's is iatrogenic, drug induced, because steroids are the most used and most abused molecules. So the commonest cause is exogenous steroid treatment. Long-term steroids causes atrophy of the adrenal cortex, and that is why once patient has been on long-term steroids, you cannot go for a sudden withdrawal. Endogenous causes are also present, though they are much rarer. If present, 85% are because of increased ACTH. So they are coming from pituitary adenoma. So after iatrogenic, if somebody asks you what is the most common cause of endogenous Cushing's, most common cause is Cushing's disease, that is pituitary adenoma. Most common cause of Cushing's, iatrogenic. Most common cause of endogenous Cushing's, pituitary adenoma, that is known as Cushing's disease. So causes of Cushing's can be classified as ACTH dependent, that is the rise of ACTH in response causing rise of cortisol. And this condition is called Cushing's disease. This leads to bilateral, because ACTH is coming from the pituitary, it will go and affect both the adrenals. So it causes bilateral adrenal hyperplasia, zona fasciculata. It also causes hyperplasia of zona reticularis because of the ACTH secretory action. Now, if it is an ectopic ACTH production, it can be ectopic also. Maybe it is not coming from pituitary, it is coming from somewhere else. Like it can come from most common cause of ectopic ACTH, small cell lung cancer. Or you can also have the MCQ, which does not cause ectopic ACTH. So lung cancer causes ectopic ACTH. Carcinoid of thymus causes ACTH production. CA pancreas and bronchial adenomas, they also cause ectopic ACTH production. Now, what are the conditions where it is not ACTH dependent, that is ACTH independent? That means low ACTH. That can happen when it is coming from the adrenal mass. So if it is coming due to a high cortisol can be iatrogenic, number one. That is number one is iatrogenic because of the pharmacological doses of steroids. Most common cause of Cushing's syndrome. Don't use the word Cushing's disease. Cushing's disease word is used only for pituitary adenoma producing ACTH. Then second commonest cause of ACTH independent is adrenal adenoma or carcinoma. So adrenal nodular hyperplasia, it can also be sometimes responsible for ACTH independent. So if it is coming from the adrenals, there will be high cortisol, and because of the feedback inhibition, there will be low ACTH. So just to summarize, causes and the level of ACTH. If it is iatrogenic, ACTH will be low. If it is pituitary adenoma, ACTH will be high. If it is ectopic ACTH, this ACTH will again be high. If it is coming from adrenal adenoma or the cancers, ACTH will be low. So let's learn some important points about the cortisol production. So cortisol, if there is a loss of diurnal variation, we just read that there is a diurnal variation. There's a early peak, then there's a 12 noon peak, and there's an evening peak. So if this loss of diurnal variation, if this diurnal variation is lost and the cortisol levels are just the same all throughout the day, that is the first symptom or sign of steroid hormone excess in the body. That is the first feature of Cushing's syndrome. Because any mass which is producing cortisol will not respect your rhythm. They will just keep on producing the hormone. Pituitary adenoma is affecting females more than males in the ratio of 4:1. Skin pigmentation occurs, weight gain occurs. So skin pigmentation is a feature of pituitary adenoma. Ectopic ACTH, again, the female is to male ratio here, it is 1:1. Skin pigmentation will still occur because of the ACTH. There will be hypokalemic metabolic alkalosis. So this is a very characteristic feature of Cushing's, and especially it is an ectopic Cushing's. And here we have weight loss. Adrenal adenomas will have size less than 6 centimeters. Adrenal carcinomas will have a size more than 6 centimeters. So if there is an adrenal mass which is more than 3 centimeter, treatment is surgery. Skin pigmentation will not occur in Cushing's due to adrenal adenoma or carcinoma because there is a feedback negative inhibition of the ACTH. And if there is no ACTH, there is no pigmentation. In case of ectopic ACTH secretion, the ACTH level is very, very high. And because of this, there is increased skin pigmentation. It will go and bind to the melanocortin receptors or the melanocytes in the skin. Very high cortisol levels will also overcome the capacity of 11 beta hydroxysteroid dehydrogenase to inactivate the cortisol in the kidney to cortisone, causing hypokalemic metabolic alkalosis. This is very important line. You have to understand that this is a feature, typical picture of hypokalemic metabolic alkalosis is a picture of ectopic ACTH production. There is also aggravated proximal myopathies and hyperglycemia. So this is because of the 11 beta hydroxysteroid dehydrogenase, which is going to inactivate the cortisol in the kidney to cortisone. This is failed. As a result, there is hypercortisolism, and this causes hypokalemic metabolic alkalosis. Now, as the tumor is malignant, if there is malignancy, there will be cachexia. There will also be classical features like the moon-shaped face, moon faces, buffalo hump, obesity. They are specifically, you will find cachexia predominates the picture in case of malignant adrenal masses. Now let's revise quickly. LMRP, the last minute revision points, which we have are USP. Hypercortisolism or cortisol producing tumors, they can be ACTH dependent or they can be ACTH independent. If they're ACTH dependent, they are either coming from the pituitary, that is Cushing's disease, or they are ectopic, coming from the lung cancer, small cell lung carcinoma. ACTH independent, most common will be iatrogenic, that is drug induced, or they can be coming from the adrenals, that is adrenal adenoma or adrenal carcinoma. Symptoms will be because of the excessive glucocorticoid, excessive mineralocorticoid, or excessive androgens. The normal values, you may sometimes be asked, or at least in some case scenarios, though you are given reference ranges. So the normal serum cortisol is between 5 to 25 micrograms. The units are very important. Don't forget the units. So 5 to 25 micrograms per deciliter, or it is 140 to 690 nanomoles per liter. Midnight cortisol less than 1.8 micrograms. 24-hour urinary free cortisol, that is 10 to 55 micrograms per day. Serum ACTH 8 AM is 10 to 50 picograms per ml. Midnight ACTH is 5 to 10 picograms per ml. Now, one important differential of Cushing's, which you should always know, if it is pseudo-Cushing's. What is pseudo-Cushing's? Excessive obesity, chronic depression, and chronic alcoholism. These three will give you a clinical picture of Cushing's, that is obesity, humps, stria, myopathies, hypertension, hyperglycemia. So this will be a picture of pseudo-Cushing's. How do we diagnose Cushing's? So first we have a screening test. So first screening test is 24-hour urinary free cortisol. This is the first test. It should be more than 120 micrograms per day, or otherwise you are dealing with a pseudo Cushing's, because urinary free cortisol UFC will not be raised in any case. Then second is midnight salivary cortisol sample. Again, if it is less than 1.7, you are dealing with pseudo Cushing's. Then we go for a dexamethasone suppression test, that is overnight dexamethasone suppression, or ODS. A dexamethasone suppression test, if the plasma cortisol levels are more than 50, next morning, if you have given 1 milligram of dexamethasone at 11 p.m., that gives you overnight dexamethasone suppression test. How do you differentiate between Cushing's and pseudo Cushing's? So you can go for a low dose dexamethasone suppression test, that is give 0.5 milligrams 4 times daily for 48 hours. Check the serum cortisol level 6 hours after stopping the dexamethasone. If the serum cortisol level is still suppressed, that means it was a pseudo Cushing's. If the cortisol levels remain high, that is the cortisol levels are high, they are not suppressed with your 0.5 milligram dexamethasone QID, that is 2 milligrams per day for 2 days, then you are dealing with Cushing's syndrome. Something which is not suppressible is a tumor. Then to confirm Cushing's syndrome, you also check the serum ACTH levels. If the ACTH is raised, you are dealing with ACTH dependent tumors, that is pituitary or ectopic. If the ACTH levels are low, we are dealing with ACTH independent tumors, that is adrenal adenoma or carcinomas. Next is to differentiate between the pituitary and the ectopic. Again, you go for high dose dexamethasone. Now, ectopic production is never suppressible. So you go for high dose dexamethasone, that is 2 milligram dexamethasone 6 hourly at 6 hour interval, that is 4 times a day for 48 hours. Check the serum cortisol after 6 hours of stopping the dexamethasone. If the cortisol remains high, it means you're dealing with ectopic. If the cortisol is suppressed by more than 50%, you are dealing with pituitary adenoma. So this is the CRH stimulation test. If you give CRH here and the ACTH is raised and the cortisol is raised, we are dealing with Cushing's. If ACTH and cortisol, they do not increase by giving CRH, because the ectopic source is not under the control of hypothalamus. It is only the pituitary which is under the control of hypothalamus. So you can also use a CRH stimulation, though we don't have CRH with us. So if you give CRH and if the values rise, it is pituitary. If the values do not rise, then it was ectopic. So just an algorithm to quickly revise. Measure ACTH. If ACTH is low, we are dealing with ACTH independent tumor. So it can be adrenals. Go for adrenal imaging. You will find adrenal hyperplasia or adrenal tumor. It can be adenoma, hyperplasia, bilateral, macronodular, or adrenal hyperplasia. If it is high, then you are dealing with ACTH dependent Cushing's. So it can be either go for pituitary MRI. If there is a tumor, then you are dealing with Cushing's disease. If there is no tumor, or if it is small, then probably we are dealing with something else. So we come to this side that it is either go for a CRH stimulation test or go for a dexamethasone suppression test. So if it is a adequate suppression happens, you are dealing with Cushing's. If the adequate suppression does not happen, probably there is a mixed response. Or if the ACTH level itself was intermediate, you could not clearly rule out whether it is ACTH dependent or ACTH independent, you go for a CRH stimulation test. If it is stimulated, then it is coming from the pituitary. If it is not stimulated, then it is coming from the ectopic source. Once again, ACTH suppressed, ACTH independent, elevated, ACTH dependent. Go for a dexamethasone suppression test, high dose dexamethasone. If it is suppressed, it is Cushing's. Not suppressed, it is ectopic. Go for a CRH stimulation test. If it is stimulated, it is Cushing's. Not stimulated, it is ectopic. Next comes the location. How do you localize the pituitary adenoma? So MRI is the best test. It will give you the mass here in the pituitary. Then most accurate test to diagnose Cushing's disease due to pituitary adenoma is you can also go for inferior petrosal venous sampling. If ACTH level in IPSS and the peripheral blood is more than 2:1, it means it's a Cushing's disease, that the mass is coming from the pituitary. If it is less than 2:1, then that means you are dealing with ectopic secretion. Because sometimes what can happen, you can have two diagnoses. There's an ectopic ACTH, at the same time there's a pituitary mass, but this mass may be NFPT, non-functional pituitary mass. So you also have to go for IPSS, that is inferior petrosal venous sampling. The treatment of the pituitary adenomas, first of all, reduce or eliminate that there is adrenocortical cortisol secretion. If it is an adrenocortical mass, you can decrease it by medical therapies, steroids by ketoconazole, metyrapon, mitotane, etomidate, aminoglutathamide, trilostan, or ciproheptadine. All these medical managements are there as good as medical adrenalectomy because they will go and absolutely shut down your adrenals. Or you can go for a glucocorticoid receptor antagonism, that is at the peripheral level, that is by mifepristone. Mifepristone has another use in empty pill. Then we also use pasireotide. It's a new subacute somatostatin analog. It acts via the somatostatin receptors to inhibit the secretion of corticotropin from the pituitary adenoma. So in case of Cushing's disease, you can also use pasireotide. It binds with high affinity to the somatostatin receptor subtype 5, which is strongly expressed in the corticotroph adenomas. First pituitary-directed agent to be approved for use in Cushing's disease. It is associated with a high incidence of hyperglycemia. We are also using Isturisa. Isturisa is oscillodrostat, which are oral tablets for Cushing's disease. Patients who cannot undergo surgery or who have undergone surgery but there is some remnant mass, then you can also treat them with Isturisa. To reduce pituitary ACTH production, if there's a large mass, you also can go for transsphenoidal resection of the microadenomas, or you can use radiation therapy. One last final step that can be done is a bilateral adrenalectomy. So what will happen if you go for bilateral adrenalectomy? Lifelong replacement therapy of the basic hydrocortisone will be required because hydrocortisone is a life-saving drug. So management of Cushing's, if it is ACTH dependent, you go for either transsphenoidal, pituitary MRI, petrosal sampling. If it is a pituitary adenoma, go for transsphenoidal surgery. Then biochemical cure, then you require glucocorticoid replacement and a annual follow-up. If there is still persistent hypercortisolism, you can go for pasireotide or mifepristone, that is glucocorticoid receptor antagonist, or you can also go for steroidogenic inhibitors. You can go for pituitary irradiations, or otherwise the last approach is you can go for bilateral adrenalectomy. And the consequence will be, what is Nelson syndrome? What is Nelson syndrome? If you go for bilateral adrenalectomy, there will be rise of ACTH. And that rise of ACTH will cause what? Blackening, hyperpigmentation. And this hyperpigmentation condition is known as Nelson's syndrome. Clinical features of Cushing, there will be symptoms of excessive glucocorticoid. That is hyperglycemia, insulin resistance, mobilization of the fat from the kidney, from the peripheral part of the body to the central part. So there is centripetal obesity, which is going to give rise to buffalo torso, moon facies. There will be loss of proteins from the muscles, causing severe weakness of the proximal muscles, that is proximal myopathies. The protein collagen fibers, they are broken down. The protein collagen fibers in the subcutaneous tissue are diminished. So there is, we just read, they causes decreased fibroblast activity. So the subcutaneous tissue tear easily, resulting in the development of purple stria. This is the typical buffalo hump. Now don't mix this with the simple obesity, because in a simple obesity also, the fat gets deposition here in the nape of the neck. But this is a typical buffalo hump. This is, you can see that this is hard and non-tender on palpation. Now, these are typical moon facies, the round facies, the steroid facies. These are the purple stria. You can appreciate the purple stria. They are not white, they are purple stria. Symptoms of excessive mineralocorticoids, there will be hypernatremia and hypokalemia. So the sodium absorption will be increased, potassium loss will be increased. So salt and water retention causing hypertension, which is sustained hypertension. Potassium depletion, so hypokalemic, metabolic alkalosis, and it will cause hypercalciuria. Now, this is a very important differentiating factor here. If you have resistant hypertension and a hypokalemic hypertension, you are dealing with mineralocorticoid excess. Resistant hypertension, hypokalemic hypertension is mineralocorticoid excess. So these are the purple stria. Then because of the increased androgens, there will be features of hirsutism. Excess androgen, that is DIA and DIAs, will cause hirsutism, acne. There can be alteration in your cycles, oligomenorrhea and amenorrhea. Then there will be osteoporotic vertebral fractures, osteoporosis. It can also cause psychosis, that is steroid psychosis. There can be decreased sleep, insomnia. Patient can have very good elevated mood, that is euphoria. Osteoporosis, immunosuppression, increased infections because of the dysfunction of the neutrophils. Their neutrophils are increased, but they are not functional. Then there can be glaucoma and eosinopenia. The most important part is to differentiate it from the Cushing's, and we learned obesity, depression, and chronic alcoholism. This we have already done here. We revised this point. So guys, this was about the basics of adrenals and also the Cushing syndrome or the hypercortisolism for today. Hypoadrenalism, that is Addison's disease, we will take up in the next class.